I think that's a very strong statement. Okay, just because the evidence quality is grade Charlie does not mean that it's significantly lower. I mean, obviously you have to think about it in that case, but the recommendation is a recommendation from the clinical practice guideline. So they've got some evidence statements within this that they cite. And then they talk about, which we've already cited the majority of these. And then they cited the potential benefits, improved ocular surface health and patient adherence to medication use, potential harms. They say no potential harms, benefits and harms assessments. Benefits significantly outweigh the harms, potential costs, obviously direct and indirect costs of testing, value judgments, none, role of the patient preferences, moderate. So I think that one's interesting, right? So when you think about patient preference, when we think about evidence-based medicine, we often get gobbled up in grade A through D evidence, but we forget about the idea of what I call clinical hunches. Hello and welcome to the Chris Gold Podcast on iCode Media. Today, I want to talk about utilizing anti-glaucoma medications and their impact on the ocular surface. Now, this might seem a little bit mundane and not all that interesting, but the recently published, and I have made comment about this on the podcast recently, is the recently published and updated glaucoma guidance from the American Optometric Association Clinical Practice Guidelines, evidence-based clinical practice guidelines, can give us some information about how we ought to consider our patients who are on anti-glaucoma medications, ocular surface disease suspects. Not in those exact words, but I'll read you their exact words. Stay tuned. As always, be sure to subscribe to the podcast, write a review, share it with your friends, and support those who
The most
support us.
common questions I get include, what ophthalmological codes or evaluation and management codes should I use? What ICD-10 codes do I need to bill with this CPT code? What CPT codes can be billed together and what can't? And my favorite, how do I manage a patient who has diabetes who comes in for a quote-unquote routine eye exam? These questions really highlight the confusion and uncertainty that serves as a daunting hurdle for providers, makes it more challenging for them to care for their patients and provide those patients with the best opportunity for a lifetime of ocular health and clear vision. That's why we built iCode Education for this specific purpose. Our mission is to provide optometrists with resources to help you understand disease states, revenue cycles, and billing and coding so that you can put that on autopilot and truly care for your patients. Check out iCodeEducation.com. That's EYECODE education.com. We've developed a premier billing and coding bundle that includes all of our billing and coding resources in one place. We also have a 10% discount code just for listeners of this podcast. Enter the coupon code EYECODEMEDIA22 at checkout. We'd love to work with you. Check out iCodeEducation.com. Hello, dedicated optometrists. Are you looking for a way to support your patient's vision and overall eye health? Let me introduce you to Vision Edge Pro, a visual performance supplement that stands out in our profession. Vision Edge Pro contains a balanced blend of mesozeaxanthine, lutein, and zeaxanthine in a 10-10-2 ratio. This combination has been scientifically shown to increase macular pigment density, which enhances visual performance, including contrast sensitivity and vision in glare situations. Additionally, Vision Edge Pro provides 300 milligrams of DHA and EPA, fulfilling the daily requirements for omega-3s as recognized by the leading health organizations. This ensures your patients receive the essential nutrients their eyes need for optimal health. Whether it's for everyday screen use, night driving, or enjoying the outdoors, Vision Edge Pro supports your patients in seeing their best. Recommend Vision Edge Pro for your patients today and help them achieve clearer, healthier vision. Contact your local MacuHealth representative for more details. Vision Edge Pro, because your patients deserve the best in eye health. Go to MacuHealth.com and use the coupon code PODCAST2024 at checkout for special discounts.
Okay, so what I wanted to do was go through some of this evidence. And so I will link to these data and the clinical practice guidelines in today's show notes. But about 3 months ago, the American Optometric Association released their new evidence-based clinical practice guidelines on the management of patients with glaucoma. And they've got some really interesting things in there. Some of them are not even related, and this one in particular is not even related to glaucoma. And I think it can get overlooked very easily by the comprehensive optometrist if they're not really thinking about this or diving deeper into it. So the first thing I want to talk about is just sort of the summary of evidence or the key to evidence quality and the strength of clinical recommendation levels. So the highest that you're going to see with the recommendation we're going to discuss today is a grade B evidence, which is actually a pretty strong recommendation. But in order to kind of refresh your memory about what these grading of evidence are, I wanted to take some time here on the front end to articulate that. So grade A evidence include meta-analysis, systematic reviews, randomized controlled clinical trials, and then diagnostic studies. Grade B evidence are randomized clinical trials that have a weaker design, cohort studies, and diagnostic studies that only have a narrow population, or the sample used doesn't reflect the population to whom you might apply the testing, poor reference standard, comparison between tests, or the reference standard isn't blinded, case control studies of a disease or condition. Grade 3 evidence are case control studies where the study of sensitivity and specificity of a diagnostic test, a population-based descriptive study of a disease or condition. They might be retrospective, they might be prospective. You might have diagnostic studies where they have two or more of the following, where they have a narrow population and or a sample used does not reflect a population, and or poor reference standard, and or comparison between the test reference and the standard is not blinded. Studies have strong design, but they're non-randomized trials. And then grade D evidence is cross-sectional studies, case reports or case series, reviews, position papers, expert opinion, or reasoning from principle. So I think that gives you a little bit of understanding or review of where we might be started here. And so I wanted to read a couple statements that you can find throughout the paper related to dry eye, and then we'll kind of read the summary afterwards. So let me pull those up.
CooperVision and the AOA have joined forces in a groundbreaking initiative to transform how optometrists treat children with myopia. The Myopia Collective aims to unite our profession and its allies to challenge the status quo and elevate the standard of care for children with myopia. Everyone is invited to become a member of the collective. By joining, you pledge to act in slowing childhood myopia progression. Membership includes regular updates and information about the collective's efforts, access to educational opportunities and resources, and insights from the ambassador optometrists who advocate for community policy and changes supporting the collective's mission. Click the link in the show notes to join the collective today. One of the challenging things with patients is when they invest in a really high quality pair of glasses and customized lenses, it can be challenging to keep those lenses clean, keep them scratch-free, smudge-free. And so we now have the ability with Crizal Sapphire HR lenses to offer our patients the best-in-class anti-reflective coating in a way that is really high resistance so that they're not having to care for their lenses as much as when those lenses are caring for them. So remember that you can provide patients that best in quality, best in class transparency, clarity, durability, and UV protection in a single Crizal coating. If you want to learn more about Crizal Sapphire HR, contact your Essilor account executive or visit Essilor.
All right, so the first one talks about the scope of the problem. Obviously, it says, early in the course of the disease, most people with open-angle glaucoma rarely present with visual symptoms, therefore there may be delays in detection, etc. And then it says, once diagnosed, even if good subjective vision is maintained by treatment, the use of medications and or surgery often leads to dry eye symptoms. So there's the first mention of dry eye. Then we have the second mention, which is talks specifically about medication use. And in this case, it's talking about beta blockers. Ocular side effects are usually mild, but include dry eye, ptosis, conjunctival hyperemia, corneal anesthesia, and blurred vision. And then we get the next citation of the general discussion of ocular surface disease and glaucoma therapy. So I'm going to take a little bit more time here and dive deeper into that. And it says glaucoma patients using topical IOP lowering therapy have a significantly higher prevalence of ocular surface disease symptoms than found in the general population. That's grade B, as in Bravo evidence, and Charlie, grade C, as in Charlie evidence. This is probably related to the drop preservatives, long treatment durations, and patient's age. More attention should therefore be given to the ocular surface status of patients on long-term anti-glaucoma medications with consideration for alternatives that have less toxic effects on the ocular surface. That's grade C, as in Charlie evidence. So then they say active ingredients, preservatives, the number of concomitant medications, the number of eye drops instilled per day are felt to be elements able to induce different ocular surface changes, potentially with synergistic effects. This is grade Bravo evidence. There is insufficient evidence, however, to suggest that patients without ocular surface disease need to use preservative-free glaucoma medications, especially if they require a few medications, 1 to 2 drops a day. And that's grade Bravo evidence as well. Anti-glaucoma medications have shown toxic effects on the conjunctival epithelium, grade Bravo evidence, meibomian glands, grade Delta evidence, so D, and the development of dry eye symptoms, grade Charlie. Use of combinations of anti-glaucoma medications are also found to be a contributing factor for the development of lacrimal duct obstruction. And then chronic use of preserved topical drops may affect the ocular surface indigenous bacterial flora. That's interesting. And long-term use of preservative prostaglandin drops have been found to affect bacterial resistance to antibiotic. That's grade Charlie evidence. So, so that's kind of the summary of actually covering in a lot of these different studies related to ocular surface disease. So the evidence-based action statement from the American Ophthalmic Association clinical practice guideline is that patients prescribed topical intraocular pressure lowering therapy may experience a decrease in tear film stability, elevated tear osmolarity, and should be evaluated for ocular surface disease. The quality of the evidence is grade Charlie. Cohort perspective, cohort retrospective, case control, cross-sectional review, position paper, and case series. Level of confidence is medium. Clinical recommendation level is a recommendation. This recommendation should generally be followed, but remain alert for new information. So I think that's a very strong statement. Okay, just because the evidence quality is grade Charlie does not mean that it's significantly lower. I mean, obviously you have to think about it in that case, but the recommendation is a recommendation from the clinical practice guideline. So they've got some evidence statements within this that they cite. And then they talk about, which we've already cited the majority of these, and then they cited the potential benefits, improved ocular surface health and patient adherence to medication use, potential harms. They say no potential harms, benefits and harms assessments. Benefits significantly outweigh the harms, potential costs, obviously direct and indirect costs of testing, value judgments, none, role of the patient preferences, moderate. So I think that one's interesting, right? So when you think about patient preference, when we think about evidence-based medicine, we often get gobbled up in grade A through D evidence, but we forget about the idea of what I call clinical hunches or clinical intuition, and also patient preference. So obviously, patients who prefer no treatment, that would be applicable in this case. And then as far as gaps in evidence, research to evaluate the complex relationship between glaucoma medication and ocular surface disease should be delved in deeper. That's a gap in our knowledge and our evidence. So I think the bottom line here is that's a pretty strong statement. And as comprehensive providers, we've got to consider how are we going to incorporate the serious evaluation of patients who are on glaucoma medications for ocular surface disease. Does that mean we're going to take a separate visit and dive deeper into just their ocular surface testing? Are we going to look at their meibomian gland secretions on a regular basis? Are we going to express those glands? Are we going to look at osmolarity? It's specifically called out in the clinical practice guidelines. Are we going to look at inflammation testing? Are we going to look at staining? Are we going to look at meibography? Really, I would say that you ought to consider that. I think when I look at this and I think about the long-term effects, and even just as I reflect back on my 17 years of clinical practice, yeah, these patients on those medications will have ocular surface instability more frequently than not, especially after a few years. So I think the bottom line and the take home is that this highlights the complexity of glaucoma management and actually highlights the value of a comprehensive optometrist managing that patient who has glaucoma in their practice as much for and as long as they possibly can, because it's in the best interest of the patient, because there's nobody better positioned than optometrists to manage these diseases. I also want to say that this is not a reason, in my opinion, not to treat glaucoma. It's not. I actually think that it in some cases, adding some of these complexities could be seen by some as in, I don't want to mess with that, so I'm going to let somebody else who's more expert mess with that. A lot of the reality is that if you have a glaucoma specialist, often the case is that glaucoma specialist is more concerned with the glaucoma than they might be with the holistic care of the patient. That is not belittling a glaucoma specialist. It's just making the case that they may not be able to pick up or have the time to pick up on ocular surface instability as much as you ought to, or as much as you will be able to. And so just keep that in the back of your mind. Think about, in your glaucoma patients, are you going to and should you actually take a separate deeper dive on some regular basis into their ocular surface dysfunction? My take home is that yes, I think we ought to be doing that. And so, in any case, I hope this was helpful. I will see you guys on the next video. Make sure you like and subscribe, share it with your friends, and we'll see you next week.
Hey, if you enjoyed this episode, make sure to subscribe to us on Apple Podcasts and our YouTube channel, both linked in the show notes. Now, here's something exciting. We're giving away a 1-year subscription to Comprehensive Optometry Simplified. All you have to do is leave us a review on Apple Podcasts, take a screenshot, and email it to me at questions@icodeeducation.com. We'll put that in the show notes as well. We'll be selecting a winner on December 15th, so don't miss your chance to get access to this valuable resource. Thanks again for listening. I can't wait to see your reviews.